But I always like to say واحنا بنstudy a case of الهرمون sometimes الناس بتعتبر ان endocrine is very very difficult يعني. But if we think of it in الهرمونز is one of the best symptoms or one of the best examples of homeostasis يعني like keeping every fine adjustments in the body يعني. So this is really the best, and if we keep this in our mind it will be more easy to diagnose any endocrine cases. So if we have the idea that we have hormone A, it leads to stimulation of hormone B, and when hormone B increases it leads to stimulation of hormone C, and therefore hormone C, when it reaches a good level, it causes negative feedback of hormone A and often hormone B as well. When there is a block somewhere, I have to know whether, and that's why when I'm studying a case of endocrine, I have to look at the whole axis. I can't just do serum calcium, it means nothing. I need to know calcium in the middle of the phosphorus, alkaline phosphatase, and parathormone, who's high, who is low. This is very important, because once there is a block, if we think إنها مثلا ماشيين على الكوبري وفي عربية عطلت، قبل العربية دي هنلاقي زحمة كبيرة جدا جدا، بعد العربية هيبقى فاضي خالص. This is how we look at the endocrine system. I need to know, is it this, is the block here, is the block here, and the block may be in an enzyme or it may be in an organ, that the problems with the organ. So if we talk about مثلا in hypothyroidism or hyperthyroidism, we have to look at the thyroid releasing hormone from the hypothalamus, we have to look at the TSH from the pituitary gland, and we have to look at hormone C which comes out of the thyroid gland. كلام بدائي طبعا. TRH is from the hypothalamus, stimulates the TSH from the pituitary gland, and then the thyroid gland will produce a T3 T4. T4 levels are normal. All this, of course, you know, will inhibit the TRH with TSH. So if we talk about hypothyroidism, all cases of hypothyroidism, whether hypothalamic, pituitary, or thyroid problem, in all cases the T4 levels will be low. So this is not a mystery. The problem is, what about the other hormones? We don't measure the TRH, we measure the TSH. With TSH will be low if it is hypothalamic or it's pituitary. In either cases, it's a central cause of hypothyroidism. So in proper hypothyroidism, we say this is hormone C, the 3T4 is low, so it sends back to the hypothalamus, back to the pituitary gland to secrete TRH and TSH to stimulate the thyroid gland. The TSH is a hormone that causes enlargement of the thyroid gland. So if I find the goiter, I know that there must be increase for TSH. And I know that there is a gland. This is to compare between children who are born without a gland or children who have a gland. The problem with Dr. Mariam's case is that he was left for a very long time. He didn't recognize the symptom. He was very active. He was a very thin boy. Usually when children put on weight, then people think, oh, this must be hypothyroidism. It's actually a very slim boy. And prolonged, untreated primary hypothyroidism will release, the child will be secreting too much TSH, and then the thyrotropes will enlarge and they cause an adenoma. They may cause compression of the rest of the cells of the pituitary gland, and the child may then have other symptoms like delayed puberty or precocious puberty, as Dr. Wigdan said. In his case, it resulted in a pituitary adenoma, and this has طبعا a mass effect. It may cause headaches, it may cause compression of the optic chiasma, and the boy, he developed visual symptoms. We don't always have to depend on visual symptoms, because sometimes the child doesn't realize that he has a field defect. He doesn't realize it until you actually test. So for all cases like this, you must ask for a field of vision. In this case, if it is a secondary hypothyroidism, and the pituitary gland is not working, or tertiary, that the hypothalamus is not working properly, then in this case, the child has low free T4 levels, but the TSH levels may be normal, and this may be confusing. So TSH, do you know the normal TSH? I'm sure you all know the normal TSH level. Yeah, so up to see people say 4, 5, the cutoff levels, they're very, but he may have a TSH level of 3. Is this normal? If he has low free T4, is it normal for him to have a TSH level of 3? No. So in this case, even though it is a normal TSH level, it's actually a low TSH level, because it should have increased. It should have gone up to 60. It should have gone up to 100. to tell me I'm working. The pituitary gland is working, it's producing TSH as it should. So if it doesn't, then it's abnormal. Okay, طبعا you know there are congenital and acquired forms, and of course the congenital, most cases are due to an absent gland, aplasia or hypoplasia. Some cases may be dyshormonogenesis, and most cases are a primary hypothyroidism. And this tells us, we'll get on to neonatal screening. Some cases may be secondary, and in this case they may be isolated, TSH deficiency, or it may be in the background of a multiple pituitary hormone deficiency. So always remember this, that if you pick up a case of hypothyroidism, which is secondary, then you must test for other thyroid hormones as well. Acquired, this child was normal, and then he suddenly comes complaining, or doesn't suddenly because it's usually gradual, complaining of symptoms, and you find that he's hypothyroidism. Most cases will be autoimmune, okay? And in this case, it may be isolated, which is Hashimoto's or Graves. I'm putting it here, it's usually hyperthyroidism. So this really shouldn't be put here. I thought I removed it because it's an autoimmune thyroid, but it's more hyperthyroidism. It may be isolated as Hashimoto's, but as Dr. Murad said, was it an autoimmune hepatitis? Because once you have one autoimmune disease, you may have other autoimmune disease, and you must keep this in mind, and they may develop over time. So you may start off with one, and then he develops other things as well. So, or is it part of a polyendocrinopathy, type 1 or type 2? Or genesis. Well, how is it acquired? Now, he's born with a dyshormonogenesis. Yes, a dyshormonogenesis is a genetic condition, and it's present from the minute the baby is born, is conceived. So he has dyshormonogenesis, but some cases develop later on in life. So, or maybe iodine deficiency, and we always knew, I don't know, سيوة حلوا المشكلة دي ولا لا، بس كان دايما I think it was سيوة مش كده اللي كان عندهم نقص الأيودين. And we are a country that is endemic in iodine deficiency, and this has an impact on our neonatal thyroid screening, which we'll talk about. Or is it congenital acquired? يعني they call this a congenital اللي هي sublingual or retrolingual thyroid. It's, you know, the thyroid develops from the root of the brain, and as it descends into the neck. Sometimes there's some sort of block, mechanical block, and then it doesn't descend correctly, and it's present under the tongue or behind the tongue. For some strange reason, this thyroid, usually the child will be okay for up to 6 to 7 years, after which the thyroid gland will then regress, becomes atrophic, and then the child begins to manifest hypothyroidism. So it's really, it's congenital, but in a way it's acquired as well, because he's okay for some time. Okay, so primary or secondary, in either case we'll have low free T4. The question of TSH will depend on whether it's primary or secondary. So we come to the issue of neonatal thyroid screening. In the year 2000, Egypt did a wonderful thing. It introduced neonatal thyroid screening, and but with a screening test, you know, it has to be cheap, it has to be cost effective. يعني I can't, ما أقدرش أطلب كل التحاليل. I have to choose one thing. Some countries they choose TSH, some countries choose to do free T4, and you know which one, of course, that we chose to do. TSH. Was this a good decision? Europe, they asked for free T4. Do you think this was a good decision that Egypt chose TSH? Why did Egypt choose TSH? Because most cases are primary hypothyroidism, so the gland is not there, and therefore in this case I expect the TSH to be high. So any baby who comes presenting with high TSH, this may have congenital hypothyroidism. Well, what about the child who has central hypothyroidism? Will I pick him up with neonatal thyroid screening? I won't, because with neonatal thyroid screening I'm looking for a high TSH. These children will have a normal TSH. So will I miss them? I'll miss these cases, but it has to be cost effective. So I'm going to pick up most cases of children with hypothyroidism, but I'll miss some cases of hypothyroidism. In Europe, so a child comes with elevated TSH. For instance, the neonatal thyroid screening, and his thyroid TSH is 15. What do I do with this case? Is he hypothyroid, or what do I do? This is a high TSH level, but we are a country with endemic iodine deficiency, and this causes our babies often to be born with elevated TSH. If I give this baby time, First, what do? I'll have to do a free T4 level. Make sure he's not hypothyroid. If the free T4 level is okay, then I can say, look, I examine him clinically, there are no signs of hypothyroidism, then I'll just say, well, let's follow this up. Let's do another test in about a week. If the level is not rising, if the level rises, say to about 20, 25, then I'm in a bit of a problem, because he is not, definitely he does not have aplastic thyroid. He has a thyroid gland. Is he going to be okay, or is he hypothyroid? What do you think? What would you do if he's... It's radioactive. Many mothers refuse it even when the child is hypothyroid. I wouldn't do it for my baby if it's... I know the gland is there. 25 is not high. Aplasia of the gland, it will be over 100. Sure. It could be dyshormonogenesis. In these cases, actually, people don't really know. It's a gray area even till now. This may be a case of something called transient hypothyroidism. Maybe an element of dyshormonogenesis, like Dr. Noura says, that the baby can overcome over time, and we're talking about a few months. So definitely, I find a little bit of elevation of TSH. It doesn't go down, or it rises even. Of course, I've done a free T4. If the free T4 is low, he is hypothyroid, he has to take replacement treatment. We come to the problem, what if the free T4 is normal, and it's good normal, so it's in the upper range of normal. Do I treat or I don't treat? This is still a gray area. Some people say, I will treat. I'll give a very, very small dose, like 12.5 micrograms, until the baby is 3 or 4 months, and then I'll repeat thyroid function, and then I can try and get him off it and see if it is okay.
Okay, what is the maximum level of TSH at the neonatal period to take the decision not to start the prophylactic treatment?
Well, Egypt actually, because we're an area of endemic iodine deficiency, when they did these huge studies in Wizard al-Sahha after the neonatal thyroid screening, and they said the cutoff value is 40. Below 40, I don't need to give. This can be within normal. Now they're saying that these children might be transient hypothyroidism, and we don't know. Will these children be okay if they pass these few months with elevated TSH, or will this impact on their cognitive abilities after that? Some parents, I had a baby come to me, and actually the free T4 was low. It was 0.6 with the minimum level being 0.8. And I said to the father, your child must take L-Troxin. He said, I'm not giving her. And then he called me and I said, you must. If this was my child, I would give. No, I'm not giving her. And then he called me after 1 month and he said, Jana is fine and her thyroid is, I think هون كان بيطمني مش بيطلع لي لسانه يعني, but what happened to this child in this period when she was hypothyroid, we don't know. We will see later on what happens with Jana. Will she have problem with subtle cognitive? For what, sorry?
If I give her just the minimum supplement of L-Troxin.
Yes.
So
what's the problem?
Nothing.
Probably no problem, especially if we're giving a tiny dose.
So I was thinking that the cut level is about 10, not 40. Yeah, I could accept.
I will repeat. Definitely, I'll repeat. Yes.
I'll repeat after.
Yes.
That. And if I find it's a lot there,
yes,
I have to do the lowest dose of L-Troxin and then to read it out in 2 weeks and let us see the improving.
Yes.
Okay, I postpone and then dose L-Troxin cut. So
I would. Yes, I wouldn't give. Yes, definitely. I wouldn't give the first time it's high. If it's 10, I wait. I'll repeat. If it's rising or it's staying around the same, yeah, I might give a small dose. So, but if it's beginning to decrease, yes, okay, then we're okay. We're probably okay, but I would repeat again until it goes to normal. Yeah.
فهمت المناقشه دي ولا يعني انا عايز اصل دي نقطه خلاف كبيره قوي يعني احنا we face a problem دي even بيننا وبين بعض.
That's true. Yes. Internationally, على فكرة, there's a very big issue about this يعني.
يعني احنا usually عشان كده برضه النقطه واضحه يعني هي الدكتوره نورا اختارت what topics. ال TSH level it is very important to know it is a normal level below 5, okay? We could accept it around 5. Usually we accept in the first neonatal period, in the first 7 days up to 10 days, we could accept up to 10. It must be higher than that. But if it is above 10, we start to negotiate. It is better to start L-Troxin and repeat again the thyroid function after 2 weeks or not. So some gambling and no, I just wait
That's
and
true.
repeat it after 2
That's
weeks.
true.
And some week, doctor like me, I might prefer to do a very low dose
That's true.
of erythroxine and repeat after 2 weeks. It is fine. I started with those erythroxine. So
That's
this
true.
is-
Yeah.
So we have to get some protocol.
Now,
for our
the new
hospital.
talk, because there is really no protocol, but the new idea or opinion is to treat, because we don't know what's happening in this period.
Exactly.
Yeah.
Exactly.
And if we talk about autoimmune thyroid disease, Hashimoto's probably is the most common, and it may start with hyperthyroidism and then turn into hypothyroidism. In children, usually it starts with hypothyroidism. Yeah. And since it's an autoimmune disease, it may run in families. So once you have one case diagnosed, and actually Dr. Mariam's case, when I told them the whole family may have it now or may develop later, so take care. And actually the mother, turns out she's hypothyroid as well, and she's positive for antibodies, so she started allotoxin treatment. Thyroperoxidase antibodies are positive in almost 100% of Hashimoto's. Also thyroglobulin antibodies are positive. You know the symptoms of hyper and hypothyroidism, but they may be very, very subtle. I'm just saying the symptoms that you all know, but they often present to us in the endocrine clinic with short stature and relative adiposity, يعني relative adiposity. يعني he's short, he may be مثلا -4 standard deviations, and he is overweight relative to his height, so he maybe -2 for weight. But we don't just look at the weight to compare to his children of his age and sex. That's not enough, because if I just look at his weight compared to other children, say he's -2, he's light. No, in comparison to his height, which is -4, he is actually obese, and we find increase with subcutaneous fat. We said this, let's turn here. So what do I do if this is a case of acquired hypothyroidism, like the case Dr. Mariam is describing? Of course I have to do free T4 and TSH. I'll find the low free T4 and increase TSH. What do I do after this? I have to proceed actually to do thyroid antibodies to exclude other causes of acquired hypothyroidism. So these must be done in all cases. Like in Dr. Mariam's case, we found a normocytic normochromic anemia, which resolves by itself because the thyroxine is important for RBC formation. Hypercholesterolemia, because the thyroid breaks down cholesterol in our bodies. And this is a hint, if any of us or any of our family diagnosed with high cholesterol, we must do thyroid functions, because the whole reason might be hypothyroidism. If I just treat the hypothyroidism, the cholesterol often comes down. Elevated liver enzymes, because the liver is responsible also for normal hepatic function, and hypothyroidism also causes like a non-alcoholic hepatitis, so the liver enzymes may be high. Most cases when you give them thyroxine, the enzymes will go down to normal. Often should we do a thyroid ultrasound, a thyroid scan for our patients? What's the difference between the scan what's the difference between scan and ultrasound? Each one has a different function. Yeah, what's the function of? Yeah, so the scan shows the function of the thyroid gland, whereas the ultrasound shows the anatomy of the thyroid gland. That's right, it'll pick up an ectopic thyroid gland as well, that's right. So because I did a scan doesn't mean I don't do an ultrasound. They each have a completely different function. It's very important, especially in case of hyperthyroidism, which might be due to a solitary thyroid nodule, which is hyperfunctioning. In this case, I need to see it because it might be a cancerous thyroid nodule, and so different. So in this case, the thyroid gland was enlarged with a heterogeneous pattern. And it tells me the size of the thyroid gland, and especially in cases of hyperthyroidism, tells me what can I expect for the future. If it's a very large thyroid gland, often these children can't be taken off their carbamazepine, that they often need to take for a very long time. A smaller gland tells me this child will probably be able to be off his antithyroid gland. MRI brains for this, but not every case, of course. If I'm suspecting it's an adenoma, and of course a visual field defect. Now for the treatment, because many children were rushed, the definition of macroadenoma is an adenoma which is 1 centimeter in size. And I just wanted to say, when you're asking for something related to the pituitary gland, always ask for pituitary cuts. These are very small slices for a tiny gland. If you don't ask for it, you won't get it. So it must be specifically asked for. Previously, they used to rush to do surgery, and then the different problems. Do we go transnasal? Well, do we go through the transcranial? What are other problems that may happen after I remove the pituitary gland, some of it or all of it? So, of course, it's better if I can. If it's not severely impinging on the optic nerve and the child isn't going to go blind tomorrow, then I can wait and I can give altroxin, and the gland actually goes down and may disappear completely. The adenoma may completely disappear. So that's it. Thank you. Yes. 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 Nothing. It's fine. Nothing. No problem. But it stays 24 hours. Altroxin stays 24 hours in her blood. No problem.
ممكن بقى